Good afternoon, everyone. Today we are going to see how to manage acute ankle sprain in sports. We are going to have a look at the mechanism of injury, what are different types of ankle sprain, when to order x-rays, what are the differential conditions that mimic these ankle sprains. We'll touch upon the management from short-term, intermediate term, and long-term perspective. We'll also review when can we allow these patients to return to active sporting activities. My name is Dr. Vaibhav Bagaria. I'm the orthoplasty and sports surgeon at the Sir H.N. Reliance Foundation Hospital in Mumbai. We all know that the ankle sprains are very common to the extent that one person out of every 10,000 people would have an ankle sprain every day. Effectively, it means that each of us here in this room is going to have 2.5 ankle sprains in their lifetime, some even more. While the ankle sprain and their management seem to be a very simple condition, often is the case that we know little and we have an illusion that we know so much about these ankle sprains just because we see them on a such routine basis. So let's get going and see what really needs to be known about these ankle sprains. So ankle is surrounded by ligaments on different sides. On the outer side, there are three key ligaments that provide stability. Number one is the anterior talofibular ligament. Number two is the calcaneofibular ligament. And then number three is the posterior talofibular ligament. On the other side, on the medial side, we have got posterior tibiotabular ligament, tibiocalcaneal ligament, anterior tibiotalar ligament, and tibionavicular ligament. Together, they are called as deltoid ligament. Now, as I said, we could either injure the outer side, which is the more common, or the inner side. So the lateral injury usually results from inversion and plantar flexion. And so if you look at this video, this lady doing the catwalk has a classical inversion of her right leg. Similarly, in this sporting thing, you can just see that the player has a very classical inversion plantar flexion injury. The other type is the eversion type along with the rotational forces, and they result in injury of deltoid or AITF ligament or more proximally the interosseous membrane. So this is a classical example of how one would injure their inner structures along with the interosseous membrane. How do we go about these injuries? We start with taking a clinical history, and often we would get a history of a pop sound while playing. We'll see variable amount of tenderness and hemorrhage at the site of the injury. The inversion sprains would be most commonly tender laterally. The syndesmotic injuries will be tender anteriorly, about middle third to the lower third of the leg. So that's how typically an ecchymosis or swelling would appear if you have a lateral sprain. And there are three important tests that we do often in chronic phase, not on an acute phase, for determining the instability around the ankle. Number one is the draw test, in which the patient is seated, the knee is allowed to be flexed, the ankle is plantar flexed, and the examiner applies an anterolateral rotatory force to the heel. It is considered positive if there is an abnormal increase in the forward movement of the talus on the tibia. The inversion stress test, in which we test the integrity of the anterior talofibular ligament. The squeeze test for the syndesmosis, in which we compress the tibia and fibula towards each other in the middle third of the anterior leg. If there is a splaying and the pain, they are indicative of the injury. The ankle injuries are classified as grade 1, 2, 3 in order of their severity, and as you would see that if there is no instability, it is usually grade 1, some slight instability 2, and if there is a gross instability, it's considered grade 3. And similarly, the symptoms and the clinical signs would match degree of severity. In syndesmotic ankle grading systems, if it is considered a grade 1 sprain if only the distal syndesmosis is involved. If the distal syndesmosis injury is combined with proximal injury but limited up to the 4 centimeters, it's a grade 2, and a severe one is considered when the distal syndesmosis and a proximal syndesmosis more than 4 centimeter is involved. When we are looking at these injuries, we must not miss out any fractures of the ankle or the foot. Commonly missed is an avulsion fracture of the fifth metatarsal base. We must also look out for the Achilles tendon or its rupture or peroneal tendon rupture. When are the x-rays indicated? If there is, so we follow what is called as an Ottawa's rule. If there is a point tenderness about the inferior or the posterior aspect of either malleolus up to 6 centimeters, or the patient is unable to bear weight at the time of injury or clinical evaluation, then we order an ankle x-rays. The other x-rays that one may need to order is a midfoot radiograph if there is a tenderness about the navicular or the base of fifth metatarsal. Now, if you look at this ankle x-ray, there are various objectively defined points which need to be marked and understood, and there is a separate lecture on the radiology of these things that will be discussed in greater detail. If you look at the first x-ray, that's how the classical inversion sprain. You can see it's opening up on the lateral side. The second two images are for the syndesmotic disruptions, and the third one shows in positive anterior draw test. As I mentioned, the Ottawa rule for x-rays, you can see that the 6 centimeter tenderness on either side of malleolus and navicular pain or a base of fifth metatarsal pain classifies for an x-ray. On an MRI, you can see these structures more clearly, and you can see that there is a tear of ATFL in this slide. So, how do we manage these? So the mnemonic priced is the most appropriate for these conditions. So you protect them, you give them adequate rest, ice it, compress it, elevate, and start them on certain drugs. Are there any guidelines? Yes. So if it's a grade 1 tear, you allow them to weight bear immediately as tolerated and allow them to do a range of movement exercises. If it is grade 2, you give them immobilization in an air splint or a cam boot along with physical therapy. In a grade 3, you give immobilization, physical therapy for longer durations, and occasionally you require to do surgeries. So as our protocols go, so any acute sprain, grade 2 or grade 2 would get a black slab immediately for 48 hours. Post 48 hours, we start an early controlled motion in a functional ankle brace, and we believe that an air stirrup brace combined with an elastic compression wrap or lace-up support is a functional bracing, so which allows them to have compression, support, and bracing in one go. At 4 to 5 day mark, we start exercise against resistance. Longer immobilization may be indicated if there is a severe injury. The aim is to improve proprioception, strengthen the soft tissue structures about the ankle, and restore the range of movement. In long term, you may think of giving them a lateral heel or a sole wedge to prevent inversion injuries. If they are performing vigorous activities, they may be given a protective bracing or taping when on field, and it is important to do strengthening exercises. Now, are all ankle sprains the same? No, they have their own dispositions, and it depends on patient to patient. So several of the lateral sprains, the symptoms may linger on for weeks and months. Syndesmotic injuries are known to take even longer to heal. Occasionally, one may see a heterotrophic ossification developing in the interosseous membrane. However, the long-term results do not seem to be affected by such ossification. If the symptoms persist, and they do in 15 to 20% of people beyond 6 to 8 months, they may require a surgical intervention. But they are not healing for more than 6 weeks. We must consider other conditions like talar dome fractures, reflex sympathetic dystrophy, chronic tendinitis, peroneal tendon subluxation, other occult fractures, peroneal weakness, or a high sprain. And in that case, you must consider doing a repeat X-rays, MRI, and occasionally a bone scan. When do you allow them to return to sports? When they have a full range of movement and strength compared to the uninjured side, when they are able to hop 8 to 10 times on a single leg, which is the uninjured side, and once they are able to do that, you allow them to run, but only gradually. So first jogging, then asking them to increase their speed, and finally to sprint. They should be able to sprint and change directions of the injured ankle before you allow them to get onto the field. Prevention is better than cure, so all these patients must be taught about bracing and taping techniques when they decide to go onto the field. There should be balance and coordination training along with the strengthening program. Dorsiflexion range of movement is very important. People who can't dorsiflex beyond neutral have shown to have increased incidence of ankle sprain, and one aspect that needs to be looked at when doing rehab is to help them achieve a greater dorsiflexion range of movement. One must look into the hypermobility issues, and education is key for preventing at least some degree or some percentage of injuries in many of the patients. All in all, ankle sprain may appear simple, but one need to be aware that they may behave differently in different people. One must customize their treatment plan. Education and injury prevention is also a very important part of the overall management of these conditions. So thank you everyone for your attention, and questions, if any, are welcome at this stage.